Hello, hello.
Perfect.
Hello, hello.
Hello, test, test, test. Testing, one, two, three. Check, 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 one, two, one, two.
Check, check, check.
You're welcome. I love this sticker. Yeah, awesome. You can have more. Oh, where's Dr. Kim? Sorry, I'm so sorry.
The reason was we wanted to change the language on the side. If we keep it here, there will be an echo. That's the reason we kept it at the side.
Apparemment, ils l'ont donné rien sans prévenir. Parce que c'est trop proche de trucs comme ça. No, it's good. It was set up so there is no echo. Ouais.
The pause was very technical, so you paused on the right thing. Very nice.
These are stickers, yes. Let me know if you want more.
How are you? We are still standing.
Hello. Hi.
Actually, visualize you and send it to my camp. They say this is the situation right there.
Hello, good morning to all. Welcome. Welcome to the first session of the Community Connect. My name is Archana. I work with GCTA, Global Coalition of TB Advocates, and it's a pleasure to chair this session because the words, it's still echoing in my ear now, like community lives matters, we need to have the treatment, we need to, save the lives of the people who are undergoing DRTB treatment now. So this is going to be a very interesting session in the sense like we'll be presenting you over the clinical trials along with the community perspectives and also the need of the advocacy, like what do we need to do now? Because we know that in the recent years, there has been development that has been happening. There are new drugs coming up, there are shorter regimen available, but it's not available to the people. Like we saw how Ganesh and how other advocates were speaking about DRTB in the opening session, like how it is affecting their mental health, how it is affecting, it really broke my heart when Ani said that she couldn't even get to terms to opening the medicine box, yeah? So we all need to do a lot, so I won't take much of the time. The first speaker we have here is Dr. Animesh Sinha. Dr. Animesh comes with a lot of experience And he has been working as an HIV, TB, hepatitis advisor with MSF. And Dr. Animes has co-authored and authored several publications on DRTB. And he has been involved in the DRTB and the clinical trials. So, Dr. Animes, over to you.
Thank you so much.
You have got 6 minutes. Yeah.
Okay, I'll try to wrap it up in 6 minutes. I've got a lot to say, but I'll try to be brief. I've got no conflict of interest. I wanted to give a brief overview on the evolution of MDR-TB treatment. So, the first MDR-TB treatments were in the 1980s in the America, and those treatments were without any kind of evidence. They involved a lot of drugs with injectables, lasted 2 years, required hospitalization, had a lot of side effects, while still having low cure rates and very high costs. In 2011, for the first time, WHO released these standardized guidelines, but not much improved. There was still the injectable in the treatment, and the success rate was still only 50%. 2016 marked a change wherein the treatment duration was reduced to 1 year with better evidence, but the side effects were still there and the treatment success improved slightly. In 2019, for the first time, we had an all-oral regimen. So the longer regimen, 2-year regimen, we had a long all-oral regimen with only the oral drugs with slightly improved success rate and lowered side effects. 2020 marked another change wherein we had an oral shorter regimen, meaning now that you had a 1 year or a shorter treatment without any injectable. And finally, in 2022, we had a paradigm shift in MDR-TB treatment, wherein you had a 6-month MDR-TB treatment, which had more than 90% treatment success and very low side effects. So comparable to a drug-sensitive TB treatment, we now have an MDR-TB treatment. What is this 6-month regimen based on? It is based on 3 studies. The first study is the NICS-TB study, which showed that a combination of bedaquiline, pretomanid, and linezolid over a 6-month period led to high success rate in previously what was defined as XDR-TB. This was followed by a Xenix study, which kind of tailored what the optimal dose of linezolid would be in this 3-drug regimen. And finally, the TB practical study, which studied the bedaquiline, pretomanid, linezolid, and moxifloxacin regimen and showed that almost 90% of patients with this regimen having MDR or pre-XDR TB had a treatment success with very low side effects. What has happened since the TB practical study? WHO released the rapid communication in early 2022, followed by the guidelines updated in the end of 2022, recommending the 6-month regimen as the preferred regimen for patients with MDR-TB. There are different toolkits, so countries which want to implement these regimens, there's a toolkit from MSF available on this website. You can scan the QR code. Also from TB Alliance, the Lift TB project, you can get the QR code there. And the WHO also has a WHO BPALM accelerator platform which can be accessed with this QR code. Despite these 6-month regimens being available for almost a year now and being recommended by WHO for almost a year now, very few countries have taken up this 6-month regimen. This is a list of the 30 high MDR-TB burden countries along with the high priority countries listed by GDF. And as you can see, only few countries which are in solid green have been able to implement these regimens nationally. The rest of the countries, all patients with MDR-TB still cannot access these regimens. So still a long way to go. The challenges currently that countries face are getting a supply of pretomanid, updating their national guidelines, or making sure that the WHO guidelines are validated within their own countries. However, there is encouraging data from the early rollout of countries which have rolled out these regimens. There is encouraging data, especially from Belarus, from Uzbekistan, Sierra Leone, and Pakistan, and we'll be presenting this at the Symposium 50, which is on Saturday. So I kindly urge you all to keep this in your calendar and attend this symposium. And with that, I'll end my presentation. Thank you so much.
Thank you. We will have the Q&A at the back, so if anyone has any questions also we can have that later. I think Dr. Animes has very rightly pointed out that even though research and development is happening, but access is a big problem. And though research and development and new drugs are being there, now let's get to hear it from what is the community perspective, what is it at the ground level. And to present this, I now invite Fumeza. Fumeza, we are so pleased to have you here. And I think many of us know over here, Fumeza is a great TB advocate, and she's also the Youth TB Associate Board Member of GCTA, and she's working as a program lead at TB Proof. And over to you now, Fumeza. Thank you.
Yes, so hi everyone. So it's been a crazy morning for me because I just came here, then I needed to be here quickly. I can't even hear myself, so okay. So I was just saying that it's been a crazy morning for me because I just came from the opening and now I need to speak here. So I have 6 minutes, right? So I'm gonna just share to you what it means for me to get these shorter drug-resistant TB regimens and also from the community perspective. Can you hear me clearly? Okay. So I'm Pumeza Tisile, and as she said, I'm also based in Cape Town, Khayelitsha, and I happen to be an ex-DR TB survivor. So unfortunately for me, at the time, these new regimens were not available. That meant that I had to take at least 25 tablets, toxic medication a day, and with an injection every day for 6 months. And the injection, unfortunately, left me deaf. I'm currently deaf, but I was lucky enough to get cochlear implants. So it was not an easy journey, and as you can see from what I'm sharing now, and the toxic drug, it's not like at the time you have to take them and then you have to go on with your lives. No, you were bound to vomit. There were these side effects, and also the irreversible hearing loss was a problem for me. So with these new shorter regimens, it's a win for us as TB advocates because we've always been fighting for this, that there should be shorter regimens that are less toxic, that people can have access to it easily. But then now the problem, as you can see from Dr. Animesh, light slide, there's a problem with access to these drugs. So as the community representative and also from the community perspective, we need to understand that this is a problem and that our voices matter. We need to fight for those people who do not have access to these life-saving drugs. Yes, there are companies like, for instance, Cepheid, who makes these diagnostic machines that are easily, it can detect what type of TB you have. But then that diagnostic is not easily accessible to people who need them the most. And then there's this BPAL, mixture of drugs that we've always dreamed of, that there should be fewer drugs with less side effects, that people can be able to continue with their lives. And still with that, there's this gatekeeping of drugs from pharma companies. That meaning that they are not giving it, it's not easily accessible because of the price. Right? So with these shorter TB regimens, it means it's really a dream to us, but then there's still a lot of work that needs to be done from countries to countries so that people can have these life-saving drugs and also they can continue with their lives. And I was able to continue with my life, although I was in this longer TB regimen, I was able to go back to university and do what I love. And I tried to sort of go away from the TB community space, but it always throws me back because there are still a lot of things that need to be discussed. There's stigma. You can be here the whole day if I will talk about all of it all. So I think that's it from my side. And yeah, if anything else, then you can discuss on the Q&A. Thank you.
Thank you, Fumeza, for sharing your story. Now we will Animesh in his presentation has said that we have got trials which has proved very effective results, but in spite of the trials also very few countries actually implementing it. So we'll have the opportunity to hear from Dr. Tiara Pakasi, who is the National TB Program Manager of Indonesia. Dr. Tiara Pakasi will share the country rollout of BPAL in Indonesia and her experience. Dr. Tiara Pakasi comes with a lot of experience. She has, among many of her achievements, what she has done recently is bringing in the insurance card in the public-private partnerships. That's one big achievement that the country has also, demonstrated recently. Over to you, Dr. Tiara.
Okay,
Thanks.
thank you, Archana. Good morning, ladies and gentlemen. Happy to be with you all. I'm Tiara Pakasi, the NTP manager of MOH Indonesia. I would like to share the BIPAL and BIPAL-M rollout in Indonesia. I'm happy to see the slide of yours showing that my country is all over green. Thank you so much for that. Yes, a little bit putting into context the situation of our country. It's I think the largest archipelagic country, and we have high burden, of course. Yeah, the second estimated cases in the world, and we also realize that we are having also the problem of DRTB cases in Indonesia, which is affecting our nation colleague. Yeah, and for that, we also have been developing and improving our DRTB infrastructures, as you can see in this slide. So with regard to our government commitment towards DRTB control, here are some political commitments, the list of presidential decree, health ministerial decree, strategic plan, and also technical guidelines of DRTB treatment. And support for our DRTB patients through several, maybe it's not perfect yet, but it's on the process. Contact investigations and case findings, diagnosis services, DRTB services, monthly enabler, and psychosocial support. And we are trying also to provide shelter if it's needed. Here is the big plan of our DRTB treatment. We always try our best to follow the guidelines from WHO. And this is the roadmap, I think, and all that we've been through. And we are happy, we were so happy that we received the rapid communication about the BIPAL, BIPAL-M. And then when we were in the middle of doing our OR, it finally came out that we can start the implementation of BIPAL, BIPAL-M regimen to our patients. And little bit story of this, behind this. So last April, we had this regional meeting in Bangkok. We shared about our progress on BIPAL, BIPAL-M, because we almost finished our OR by that time. And then when I returned to my country, we reported the result to our minister. And then he said, no, start implementing it in limited areas this year. When will you finish your OR? June, sir, and then start in July, immediately. So by that time, we really started preparing our human resources, of course, all the resources that are needed, like to roll out this initial implementation towards nationwide programmatic of BIPAL, BIPAL-M. So here is our timeline, I have, my heart beats faster every time I read this roadmap, but I'm sure if we are together, the government, the physicians, communities, I think we can do it. So here is the timeline, and this is the result so far for our BIPAL, BIPAL-M implementation, starting with the OR and the early initiation, for programmatic. And we are happy that we reached the treatment success rate of 97%. Maybe a round of applause for the patients and the physicians. Thank you so much. But there is a but. Now, our clinicians has to close the tap a little bit because we are still waiting for the pretomanid to arrive in our country, which we have been ordering since I think the early year of 2023. So we are really hoping that we will receive this pretomanid very soon. So here is our plan. Of course we need to still strengthen and maybe adjust our regulations, and we need to prepare our healthcare facilities because in some cases we really need to increase the capacity and also the confidence of our clinicians, and also we need to have or strengthen our lab capacity, and also about our healthcare workers, about the logistics that has a main issue or need to be focused on, and also about the community role, of course. We really need capacity building for our communities, especially our TB survivor groups, so that they can educate or support the peers, to enroll in treatment, because one problem of DRTB cases in Indonesia is we have pretty low enrollment. I mean, there is a gap between the confirmed cases and the enrollment. So we have initial loss to follow-up still a problem, and we need to tackle this, and hopefully this shorter regimen BIPAL-M can tackle that problem. But of course, on the other hand also, we must put also the understanding that the decision of having the disease is decided by the clinicians. Yeah, that needs to be balanced. And of course, about the funding, we really appreciate all the support from all the donors, partners all this time, but we are really proud that we also have some national funding sources for this DRTB management. So I think that's the end of my sharing, and here is some acknowledgement to all the related stakeholders that is really supporting us. Thank you so much.
Thank you, Dr. Tiara, for sharing. I mean, that's an excellent example of the country that you have, and we need to learn and adapt it, because unfortunately there are many countries who keep on analyzing things and if what, and it goes on if, and implementation doesn't happen. So I think we should arrange for some kind of exposure visit to your country for all those countries. Yeah. Thank you so much for sharing that. And next next speaker is Robin. And Robin is actually, the main thing about like what we have been discussing from previously onwards. Like we have the evidence, WHO evidence, the evidence, the trials, the countries, and also the WHO guidelines, but still access is a big problem over here. So Robin is a advocacy access lead, and she will be sharing her experience of the multi-country this thing. Robin holds a PhD degree and she's an independent consultant, and many of us must be familiar with her because she was one of the lead person for the UNHLM activities in mobilizing all the communities and the thing. Over to you, Robin. Thanks.
Thank you. Hi, everyone. Okay, I think we're getting this up. It's up. Okay, so my name's Robin. Nice to see you all. As Arshana said, I work as an independent consultant in the fight against tuberculosis, and today I am here in my capacity as the Access Advocacy Lead with TB Alliance. So I do receive consulting fees from them. And I want to share with you a little bit about a multi-country consortium platform working on accelerating the uptake of BIPAL-M, and it is called Fast Track the Cure. You can see on screen our logo and our implementing partners that we kicked off with in 2023. So 2023 is really our pilot year, and what we're working on doing together is putting in place a scalable and replicable access advocacy model that leverages both traditional advocacy and social media advocacy tactics to raise awareness of new regimens and ultimately increase demand for them from grassroots levels. So impact then means adoption and availability of BIPAL-M right now. And this is critically important. As we've heard already throughout the day, this new regimen is shorter duration, down from 9 to 18 months for treating DRTB to just 6 months. It's less pill burden for people taking treatment, less side effects, and way better cure rates. So 90% cure rates, which is way better than the less than 60% we've seen with conventional DRTB treatment regimens. So right now, we've got partners that are working on Fast Track the Cure based in Vietnam with SCDI, based in India with GCTA, based in the Philippines with TB People Philippines, and based in Indonesia with Team YKI. And what are partners doing? Our implementing partners are engaging in national level advocacy. So you can see here on screen, Team YKI is doing lots of work engaging with the Ministry of Health, supporting their uptake and rollout of BIPAL. In the Philippines, there's a decentralized model of healthcare rolling out right now. So TB People Philippines is working with cities and mayors to raise awareness about BIPAL and get their commitment to support its uptake and rollout. In Vietnam, our partners were working on making sure that BIPAL uptake was included in Grant Cycle 7 for the Global Fund proposal application process. And I'll let Richa tell you more about what Team GCTA is doing in India. But in addition to these traditional advocacy campaigns that are being led by partners, we're also collecting BPAL user stories because we want to share these stories with others around the world. So Indonesia, for example, is really leading the charge. So they have people who have already been treated with BPAL, but some countries haven't even started rolling out BPAL. So can we share stories from the ground from Indonesia with others that encourages countries to adopt who might not be adopting right now and raises awareness to people who are affected by TB that might not be aware that these treatment regimens exist? BPAL is my right? That's what India is saying. So making sure everyone's aware that they exist and making demands for access to them. And I just want to share here on screen, actually, one story that has been really powerful was one from Joe from the Philippines, a survivor of XDR-TB, one of the first people treated with BPAL. His story was shared quite widely, and the Union Conference actually invited him to be the keynote speaker here. Unfortunately, he did not get his visa and was not able to be here, but the power of his story is great, and I'm hoping that everyone here can help support amplifying it, sharing it more widely, because it was really a shame not to be able to hear from him directly today. So online, we're sharing these stories. We also have a petition that's calling for access to BPAL by the end of 2024 in full alignment with the 146 campaign and also the Stop TB partnership kiosks that we pushed for around the HLM. And Priyanka, might I ask you to pass these out? This is just a little QR code that you can scan. It'll take you right to the petition and you can sign it right here, right now. On social media, follow our hashtag 6monthsmax. And just to flag, we just started new social media accounts. So there's now a Fast Track to Cure Instagram account and Twitter, just newly launched the other week. So lessons learned and next step, this really was year one, so we're learning as we're going and we're building as we go as well. We have plans with our implementing partners to expand and grow from here, continuing to work together in 2024, but also ideally bringing on new implementing partners with grants to engage in Fast Track to Cure advocacy. We have endorsing partners at the moment too. Endorsing partners generally support the cause and the call, and they take light touch action to amplify the work that implementing partners are doing. So if you're not an endorsing partner and you want to become one, let me know and we can make that happen. And then sponsoring partners. Right now, Fast Track to Cure is predominantly funded by TB Alliance, but it would be great to have other donors on board as well. Okay, and before I close, I'd love to take a little action with all of you, if that's okay. So on social media this week, we're going to be amplifying the stories of all our partners. And I'd love to have you all, if it's okay, just quickly say, Fast Track to Cure, 6 months max. Fast Track to Cure, 6 months max, okay? Can somebody lead the chant for me so it's not me leading it while I film it?
Fast Track to Cure, 6 months max.
Okay.
Fast Track to Cure, 6 months max. 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 Great.
Everyone everywhere needs access to BPLM. Let's make it happen.
Thank you, Robin, for bringing out the power of social media advocacy. So our last speaker is Richa. Richa is my dear colleague at GCTA. Richa is a communication expert, and she has worked with environment and conservation, but she's now all for People Center and TB rights advocates. Yeah. So Richa will be sharing the GCTA experience on community rights to safer and newer drugs. Yeah, over to you, Richa.
Hello, everyone. Excited to be at my first union conference and seeing such strong community voice represented. I'm going to start off by talking a little bit about tuberculosis in India. With the incidence of 2.8 million last year, India continues to be the highest burden tuberculosis country. And with 113,000 people with DRTB last year, still the largest number of people with DRTB is in India. Yet, there's no BPAL-M available to the population. India did have a clinical trial with 400 participants over 8 sites. We don't know what the final cure rate was, but the intermediary results that we got access to was over 85%, which is still 25% higher than the conventional regimens that is still the only one that's still available to people in India. So we decided we have to do something about that at GCTA. We started off by mobilizing TB advocates. People like Meera Yadav, who's an ex-DR TB survivor. Her own battle with TB lasted over 6 years. She lost a lung and was only cured when she was given access to the then new bedaquiline. So medical, scientific innovation, she's a huge fan, and of BPAL too. So she's made a compelling video. So have Shabana, Arshi, and Eden. All of them are TB champions, work daily supporting and helping people with tuberculosis, and they feel BPAL can give new hope to these people. Then we have our very own Blasina Kumar, who's been a TB activist for over a decade. And she speaks in the video eloquently about how BPAL is not only great and wonderful for the people that need it, for people with drug-resistant tuberculosis, but also really great for the governments because it's a huge cost-saving deal. So we got all of these amazing videos on our social media. We also decided to do some grassroots advocacy on the heels of World TB Day this year earlier. We wrote a letter to the Prime Minister. It was signed by over 600 civil society and community members and made a case for the Prime Minister leveraging World TB Day to announce a rollout of BPAL. We did not receive a response. We also supported Meera Yadav's change.org petition, where she talks about how BPAL really helps with India's goal of ending TB by 2025, which is 5 years ahead of the SDG goals. Still no effect, and because we don't give up, we wrote a follow-up letter to the Prime Minister. This was endorsed by civil society organizations and spoke of the 64 countries that have already, in some capacity, rolled out BPAL and the amazing results coming out of these countries. Not a surprise at this time, but we did not receive a response. So we decided we're not giving up. We're going to set up an expert think tank. This expert think tank is made up of prominent lawyers, journalists, TB survivors, activists, and civil society. One of the first things to come out of this think tank was an article which actually spoke about the BPAL trials in India and kind of gave light to the results, which we didn't have access to back then. I would love to talk about more that's happening with the expert think tank, but there's things coming up, and I hope to be able to share them with you soon. We also developed a community brochure and a training manual because we think it's important to educate, create awareness, to create demand, and also do treatment literacy. Both these documents are in their final stages of finalization. We hope to have them out before the year is done. We have also been really active on social media over the past year. We have been part of Fast Track the Cure's 6 Months Max campaign. And one of our latest stories, which we are really excited about, is Miriam's. It's not her real name. She's a 43-year-old woman who was part of the BPAL clinical trial in India. I'm just going to read to you what she said. I had no side effects. Now my weight has increased and my appetite is back. I did not have any difficulty. With God's grace, slowly everything has become normal. And I think, isn't that a story we want to hear much more of with people who have had to fight this disease? It's time for 5. We need Danaher and Sapphire to drop their prices of XDR tests because medicine and tests and healthcare cannot be a privilege. It needs to be accessible for all. It is a human right. Thank you so much.
Thank you, Richa. I really like it when she says that we don't give up. We don't give up, but there is also a saying in my the place from where I come from that it's very difficult to wake up people who are pretending to be asleep. But still, we need to wake them up, I think. We need to wake them up. We have got evidences, we have got guidelines, we have got people's story. So thank you for sharing that. We're all doing what we can, but we still have a long way to go. We are not giving the right treatment to people who really need it at a ground level. So we have some time for Q&A if anyone would like to there's also a Slido app which you can use and put your question, or otherwise you can just, stand up and we can pass over the mic and ask. If not a question, any comments or any feedback or any sharing?
Or any suggestions
Yes.
to wake people up that are sleeping?
Since no one is asking and will be shunted out of here, if you had XDR TB, if you had pre-XDR TB, what would you like? Would you like the 18-month, 22-month long treatment, or would you, or if you were given a choice, or would you opt for the shorter, all-oral, less toxic, less pill burden regimen? How many of you would like the long treatment? Please raise your hands. How many would like the shorter regimen? Yeah? So if we do, and our countries are not providing that to our brothers and sisters, I hope that when we leave from here, we make a commitment to demand so that people like Fumeza don't have to live with becoming deaf because of these toxic drugs for the rest of their lives.
Yeah? Any questions from the panel speakers? Any comment? Any last comment?
I actually would love to hear more from Dr. Tiara about the rollout in Indonesia. Other than the challenge with the procurement of Pretominid, have there been any other challenges? And in your opinion, because you've been through the process, what can we do better as activists in India or other parts of the world to roll out this amazing regimen?
Okay, thank you, Rika. I think I quote from you, we never give up. I think that's a big capital that you should keep flaming, yeah, because actually to be able to do this, first we need the political commitment. So we are very grateful that we have our Minister Budi. That, well, it was a hardship for us, like to follow all his instruction, but then on the other hand, we also have someone to rely on, that yes, we are not alone. We are with our leadership, we are with community, we are with our partners, etc. So never give up, and then collaboration, and then always open mind, open-minded, and maybe we need to have a better communication. I don't know about your country's context, but I think being humble, in each of us, starting with us, and then always seek for help and guidance. Of course, that is important, because otherwise, if we put ourselves far in the seventh heaven, maybe in our terms, then it never happens. Yeah, I think that's the simple way. Yeah, but of course, to achieve it, then it's a hardship. Never give up.
Just, I don't know how much time we have, so if we're all going to be leaving here soon, I just wanted to flag that if anyone here is working for a civil society or affected community group that would want to come on board as a Fast Track to Cure implementing partner, we are looking to expand. It's grant-funded participation and totally led by what are the needs and interests within your own country context. And essentially our partners develop their own advocacy strategies and then roll them out and implement them throughout the year. So just flagging, if you're interested, do reach out, or if you want to become an endorsing partner, come find me after, we can make that happen.
I guess there's no more questions. There is nothing from the audience, and we don't have much time also. So I think it's time for us to end the session. Thank you, speakers, and thank you all for joining over here. I think we should now all go back, and as what Dr. Tiara says, context is what it matters. Whatever be the guidelines, evidence, trials happening, but context is what it matters. And we need a great NTP minister like you in each and every country. So let's all come back next year. And let's make sure that the slide which Dr. Animes is on, it's all green. So Bipal is all right. And another announcement I would like to make is that we also have a booth GCTA. Please drop in, please come in, and we can continue the discussion over there. Thank you all for joining. Thank you.